I invite Dr. Bart now to come up on stage and give his keynote address and chair the remaining of the session.
Thank you. Good afternoon. Can you hear me? Yes. Okay, it's a pleasure for me to not only chair this session, but also give a presentation on a vast topic, equitable healthcare provision. And I'm going to try to cover this huge subject in 15 minutes. If I am not succeeding in doing so, please give a sign after, so that I can wrap up. The title of the session is actually Towards Equitable Healthcare Provision, and I've added myself and beyond, because I think that healthcare provision is a means to an end. We need to look further than only the mere provision. Actually, in this presentation, 3 points I would like to make. A first point I would like to make is that, as I just said, that equitable healthcare provision is only a starting point, and that eventually, well, the goal is equitable utilization. Not just any utilization, but equitable utilization of quality healthcare. A second point I would like to make is that, well, if we situate ourselves in a social determinants of health perspective, and I think this is very much the case at this conference, well, healthcare service provision should go beyond healthcare provision, rather, should go beyond health services provision. Something that is relatively obvious, I think, for most of us here, and it has been emphasized already a couple of times this morning that we should go beyond services. And a third point may seem a cliche, something everybody agrees with, nobody disagrees with, just emphasizing again that it is difficult, it's a difficult endeavor to reach the most in need of care. Not only in India, but everywhere. Also in my country, in Belgium, this is an issue. And there are no simple solutions. On this first point, I want to share with you a rather old model, an old paper. Perhaps the ones of my generation here in this audience will know this, recognize this paper. It's the famous Hashi model, which was published in 1978 in the Bulletin of the WHO. And I think it sets nicely a frame to reflect about coverage, equitable healthcare provision. And in fact, what Hashi does is he somehow breaks down coverage in a number of steps. And I think this is useful. It is useful to think this way. He starts with availability coverage. People for whom the service is actually available. And to some extent, when we say, well, in the title healthcare provision, well, you can, if you reduce provision to the health services there, it's available. This model somehow illustrates that this is not good enough. From availability coverage, there's accessibility coverage. People who are in a position to use the service, and this in itself is also something that has multiple dimensions, different components. And from accessibility, there's acceptability coverage, which again is a mix of a range of factors, as well at the demand side as the supply side. It has to do with quality of care, how people perceive their illness, etc. Eventually, there is contact coverage. That is, people who, after having gone across all these steps, take indeed the initiative and contact the health service. And then the fifth one is effectiveness coverage. People who receive effective care. And here, for me, quite central is the notion of quality of care. People who receive care that is of good quality. Effectiveness being one of the dimensions of quality of care. So this is an interesting way of thinking. And as you see in this scheme, in this curve, people are lost, dropping out at every single step. So it may be a useful tool to break down provision and actually to identify bottlenecks. Acceptability coverage may be, for instance, a greater barrier than accessibility coverage. depends a little bit on the context. So it's useful to identify bottlenecks, to analyze also the constraining factors, and from there on, identify the most appropriate and the most optimal action. So this is a first idea. As I said, effectiveness coverage is about quality of care, and I don't think it's an excessive luxury. I want to say a word on quality of care, because this in itself already is a vast subject that could be an entire EPHP conference on quality of care. I stick to this definition, which comes from the Institute of Medicine in the United States of America, and I think it's I find this a relatively interesting definition because it seems universal. I recognize it as being something that is relevant also for low and middle income countries. Quality of care is care that is safe, that is effective, that is patient-centered, that is timely, that is efficient, and that is equitable. Big challenges. Going back to that model of Hashi, all these different steps, but eventually having access to care that is quality care. It's also, I think, an interesting issue to keep in mind in universal health care, universal health coverage policies, UHC policies. It's about facilitating access to care, but what sort of care? So quality should be a big, well, reference there. First point I wanted to make. The second point, and as a starter, I was looking in my bag for the quote, but I think I may have left it in my room. But basically what Upendra Bojani is a faculty of the Institute of Public Health and doing some work in KJ Halli, which is an urban area in northern Bangalore, and he has been investigating access to healthcare by diabetes patients. And his research indicated that people, in fact, experience lots of obstacles that have nothing to do immediately with the health service, that have to do with their insights, with their knowledge, with their financial resources, with the information they received, whether this is understandable, etc. Things I think we all know. We are all very familiar, I think, with the many obstacles that people experience in accessing quality healthcare that go beyond the pure health services, that have to do with just the social environment in which people live. And I wanted to share with you this scheme, which is coming from a WHO publication, quite recent, 2014. As you may know, there is currently quite a dynamic within the WHO to emphasize people and person-centered healthcare. And what this scheme basically illustrates is that if we want to go for a people-centered healthcare that is universal, equitable, integrated, etc., there's not only the health service, there's not only this blue circle, but there's this overlap with the other sectors. Education, sanitation, social assistance, labor, housing, etc. This again is not new. But the challenge is, certainly not at a decentralized level, these other services are not necessarily there. You may have, if you take the case, let's take the case of the PHC in India. PHC in India, well, it's relatively decentralized. You still have sub-centers, but it's one of the most decentralized structures. You have health services, but you do not necessarily have at a decentralized level an interlocutor that is involved, for instance, in social assistance, or that is involved in water and sanitation. So it's good to have that scheme in theory. In practice, it should be there. It should not only be there, there should also be coordination between these. They should interact. If these services are there, if they are there, and very often they are not, then they tend to operate in silos. So a challenge is, if we want eventually, through equitable health coverage, offer quality of care at the end point, it's not only health services, it's not only health care, it's an interaction. I mean, in order not to medicalize social problems, there should be an interaction with social services, but they should be there and we should link up with them. Boundary spanners is a term and a concept I discovered only recently. And I'm in fact charmed by it. It comes from the public administration sciences. And it's about people, individuals very often, that try to span, to bridge the different sectors. You know, act a little bit as an intermediate, and if we translated to our discussion would be people who actually bridge the health services at the decentralized level, for instance, with the other services. I think it's an interesting concept to reflect further on. It seems there's quite some literature of this. It has been developed, as I said, in public administration sciences, and it could be an idea also to integrate in possible action in the future if we want indeed to advance in the direction of equitable healthcare, equitable quality healthcare. The third point I wanted to make is that I said making healthcare accessible to all is a difficult exercise in all circumstances, wherever we are. This comes from the National Health Service. John Hart is a general practitioner working in the National Health Service in the early 70s. In a system where there were no fees. Access to healthcare to the general practitioner was free of charge. Nevertheless, on the basis of his evidence, he noted that the availability of good medical care tends to vary inversely with the need for it in a population served. And this inverse care law operates more completely when medical care is most exposed to market forces and less so when such exposure is reduced. So even in a context, a high-income country context, like the UK, but this is also the case in my country, Belgium, evidence shows that 15% of the population is not in a position to use the primary care services because of a range of constraints, even if financial access is very minimal. Financial barriers are very minimal. So this inverse care law is something we should keep in the back of our minds, and it requires constant attention and focus. A paper on work that has been done in Africa, in sub-Saharan Africa. Quite some of my experiences is in that part of the world. Well, there is a big debate ongoing on okay, how to improve access to the most poor, the destitute or the indigents. This is not a term you use in your country. You ought to talk about above poverty line and below poverty line. But this research, and it's just an example of lots of other research going in the same direction, illustrates that even if you exempt people from user fees, it's still not good enough to facilitate their access to care. And it says, excuse me for the small letters, interventions combining user fees exemptions with actions targeting other obstacles to healthcare access would probably be more effective. So other things need to be done at the same time. Let me illustrate this with this scheme. It's not only good enough to offer vulnerable people a ladder to look over the wall. One ladder is not enough. You need several ladders. If you have the ladder, I exempt user fees, there are still other ladders that are needed. But having the ladders in itself is not enough. You need to be in a position to use them. You need to know how to use them. And this is about people's capability. So, and they are not, by no means, equally distributed as we know. So necessarily action is going to be multi-pronged, beyond only the most obvious factors like geographical access, financial access, etc. I'm wrapping up with these three take-home messages. I think it is useful to deconstruct healthcare provision. There's a long and complex path from healthcare availability to effective utilization. Effective utilization meaning people eventually benefiting from quality healthcare, not just any care. Second, I think a second avenue for thinking is it is important, it is relevant, it is necessary to create bridges between health and other social sectors. Social welfare, education, housing, etc. And there's a key role for stewards of local health systems. Perhaps these stewards, or some of these stewards, could be the boundary spanners, bridging the different sectors. And the third message, We should be aware of this universal, I think. I formulate the hypothesis that this is universal inverse care law, even in very elaborate health systems. It should be really a main concern. Thank you very much.